So our next presenter is Keith Atwell. He's been a perfusionist for almost 20 years. He's currently at the University of Tennessee in Knoxville, where he's been for 16 years. He's been the chief there for the last 8 years. He's also very interested in educating our students, has really dedicated his professional life to helping others, as many of us have done throughout our careers as well. However, he's also served all of us in the United States Air Force for 10 years prior to becoming a perfusionist as a firefighter and a first responder. So, which each of you would welcome him, thank him for his service, as well as welcoming him here to discuss a case study on something that I hope I never have to experience. Keith?
So I will tell you that it is a tough act to follow, Dr. Baker and Paige. I mean, those were both great talks, but I know it's right before lunch, and this may want you to rethink about lunch after you have this case, but we'll see. Quick poll to the audience. How many in the room have done anybody over 500 pounds on pump? ECMO? ECMO or pump? So 5, okay. How many of you went tandem with your oxygenators? You did? You didn't use it, okay. Okay, so we're gonna set the stage, a little housekeeping. I don't have any disclosures to disclaim, so we're gonna jump right into this, and I want this to be a good audience participation, so I'm sure there will be lots of questions at the end. So setting the stage here a little early. This was a 46-year-old male who was previously seen by CT surgery 6 months prior with a dilated or enlarged root. And at that time, he had actually weighed 35 more pounds than what he did before he dissected in our OR. Our CT surgeon at the time told him, I'm not going to see you for another 6 months, or at least till you lose 200 pounds. So sad thing is he lost about 30 and it almost killed him. So he presented October of 2023 to the ER with numbness in the left arm, lower back pain, shortness of breath, all the signs and symptoms that you would of a normal aortic dissection. And one of our surgeons emergently brought him to the CTOR. And for a little context, the patient beat me there. So this was right about 4:30 a.m. in the morning on a Saturday. So imagine walking into that. So there's a little history of etiology. As you can see, type A, his dissection measured 7 centimeters. So he was a Marfan's patient. Large root, dissection flap extended into the ostium coronaries, bicuspid valve, severe diabetic, bad ketoacidosis, ARF, et cetera, et cetera. You can see the whole way down, morbidly obese, obstructive sleep apnea, and he had a bad chronic 6 centimeter umbilical hernia with uncontrolled hypertension, and that was his pressure when we hit the room. Allergies at the time, unknown at presentation, so we just listed it as no known drug allergies. So you'll find that interesting when we get into the post-op care of this patient, so just keep that in mind. Admitted at 232 kilos and a height of 203 centimeters. So this is what I calculated BSA. So everyone get ready. Full flow, 8.3 liters a minute. At a 2, 6.9. At a 1.8, 6.2 liters per minute. This was his initial gas coming in the room. So at 510 pounds of a 42 crit, there's a lot going on there up in my mind. So this is what the surgeon first came to me, and they're like, okay, this is what we're going to do. We're going to 10 millimeter cannulate the innominate artery. We're going to use a straight 3/8 connector to connect, which we used O-silk sutures to hold on to. And they wanted to bicavally cannulate because they were worried about volume. I mean, normally we use a double stage 36-46, but they wanted to cannulate for all possibilities to include RCP and selective ACP. So surgeon was like, well, cool to 28. And I'm like, 28? Circuit rest with selective ACP. They did bilateral radial art lines. We're going to do an ascending repair, Bentall procedure, and let's try to hemoconcentrate if possible. So this is what started going through my mind, because I do have the opportunity and the pleasure to teach some of the UT biomed students fluid dynamics. So all these beautiful calculations started coming back from school and what I teach from Ohm's law and Poussin's law. And I just started throwing a lot of that right out the window because I know I didn't really have a choice either way or not. So Reynolds number on 3/8 inch tubing, as most of you know, we're going to hit turbulent flow. So we all know above 6 liters per minute, your Reynolds number is pretty much exceeded before you start getting eddy currents and all that good stuff. So what was my volume demand? What am I going to have to accommodate for as far as volume return? My circuit initial prime volume was 900. Selective ACP, what do we flow? Do we flow kilogram weight? Do we flow corrected BMI? Do we flow a standard cardiac index? Are we going to go alpha versus pH? Am I going to be able to meet the oxygen demand on this acute respiratory failure patient that's already in the room anyways? And then we were using a roller pump at the time. Yeah, I was waiting for that. So the good news was we did have an extruded tubing from 3/8 to a 1/2 inch. So we do minimize our circuit a lot, and full flow on a 1/2 inch boot for 8.3 liters a minute is 175 RPM. Anybody ever maxed out your roller pump? I didn't either, thank God. So current circuit was a S5 Limanova, had a roller head, and we were using arterial and venous Terumo CDI. We were using an FX25 for an inline standard with the inline filter, and we always have a 3/8 pack. So I immediately decided that I was going to upgrade to the 1/2 inch venous line. And these were the characteristics of the oxygenator that we were using. So as you can see, 8.3, 7 liters per minute. This is all calculating in my head. O2 transfer rates. And then I talked to the doc. I said, look, neckline's going in. You got to give me 10 minutes because I got to get another oxygenator cut. And I decided to go tandem. So my worry wasn't going cold. My worry was more what was going to happen when we start to warm back up. Because as you all know, oxys nowadays, they're built to, really take a beating. And a lot of the times you can, I'm on record, but you can overflow slightly more than what they're rated and you'll be just fine. So circuit flow path that I created was, we had the 1/2 inch venous line that we cut in the first reservoir, which went to the arterial roller pump. Then from the roller pump, I wide out to the inlets of the FX25s. And from the oxygenators, I wide them back to the arterial line. And on every circuit that we have a bridge pre-reservoir and post-arterial line for safety devices and de-airing. It should happen or occur. So there's a picture. You see the roller head in the top left corner there. But from the outlet of your roller pump, that's the inlets on the yellow arrows going into the inlets of the oxygenator. That's it coming back out. You can see from your right and the left there. And then what I decided to do was I split and wide the gas line from my blender. I was kind of prepared for it. I had an extra oxygen tank in the room in case I needed it, but I thought that would suffice. And the last thing I did to prepare for volume was I had grabbed a holder and I put a standalone second reservoir on a different holder there on the bottom left, you see. And I took a quick prime spike and I cut off one of the ends and popped it into one of the side ports on that second reservoir and into a bag on the other side. And what I did was, if you see on the very bottom there, you'll see a piece of tubing. I know it's kind of hard to see there, but if I started filling that thing up, I had the ability to raise that reservoir up so I could drain back into the first if I needed it that bad. So, but the good news was during HCA, after I determined that I didn't need that second reservoir, I was able to pop that piece of tubing off. And hook it on to do a connector to a hemoconcentrator, and that's what I used for the hemoconcentration line off the recirc. So case. After heparinization, that should be a 10 millimeter graft, not an 8. It was placed on the innominate artery, and we gave 80,000 units of heparin. And we stopped at 584 seconds, even after 80,000. We do run HDRs with candy stripes, so, and his slope was 84, so nothing unremarkable there, 80 to 110 normal. So perform wet to wet, rolling up with a 3/8 connector on the graft, pulse style correlating, all the good stuff. Test estimate normally, the pressures were within appropriate limits. We cannulated with a 28 French SVC and a 34 IVC, and we put a connector with a lower lock in the center. So if we had to do RCP, we could. We wrapped the nap for -600. Total prime volume was 300. Didn't account for the extra oxy there, so that was another 260. So your total prime volume was about 560. Thankful for that. On pump, initial flow, obtained 7 liters per minute at 100% FiO2 at 8 liters of sweep. Back pressure was 218, and I initially had 1.5 liters per minute, but I could see the AP waveform still screaming. Like we were just pulsatile as can be. So they turned on the LV vent, and as you can imagine, let it rise. So initially came back 3 liters, 3.5, and I'm like, man, we're definitely going to the second reservoir when we circ arrest. But the blood pressure initially was 85 millimeters of mercury, which I set the isophore into 1 Mac. So first gas, immediately started cooling when we went on. And this is what we got from your iStat. You can see on the venous side, I always run on venous first because I want to know how we're doing coming back. And I pretty much rely on the arterial CVI. So that's what it looked like in the beginning. So we cooled, and we were cooling to 28. Cross-clamped the heart, proceeded to arrest with an initial 400. Didn't do anything. Turned my LV vent down. So the surgeon performed an aortotomy subsequently and then gave osteoplegics, 600 each on the left and right, and that is del nido. We cooled for 55 to get to 28 degrees. No problem with the gases, as I said before, with cooling. They cut out all the valve, placed the sutures for the new root, and the mean pressures were routinely 80 millimeters of mercury. I had to work with anesthesia to get medicine. I turned my MAC up to 2, and they started giving nitro just to keep it at 80. So as I mentioned before, he was chronically hypertensive. So ACTs were normal range during the case. Right before circ arrest, I got concerned because my venous sat was still at 88% before we circ arrest, and they were ready to go and start draining out. So the awesome surgeon that I worked with that day, I voiced my concern to there, and he said, Keith, like, this good gentleman lost the ability to cool further about 20 cheeseburgers ago. So I was like, okay, that's not very nice, but we'll go on from there. This was another consideration I had, ACP. I mean, normal flow 5 to 10 mils per kg. We were shooting for 50 to 60 on the right A line, but that flow was just like, man, that's rough. So we'll go low and we'll see what that does. And that's what I did. Proceeded to HCA, adjusted all my gases accordingly, drained out, and boom, opened up my bag because the volume was definitely there. I did achieve an ACP flow after I had put the hemo in of 1.6. And on the roller, we didn't have flow probes, so I cranked it up. I went to 1.2, but I accounted for an extra 400 for the hemoconcentrator shunt. And HCA was about 41 minutes, and we did ACP the whole time. We showed in the 30 millimeter hemoshield graft, and right before initiation, I started cranking up my gases because that's what I was concerned about. And your initial pressure was right at 90 at a 1.6 index at 28 degrees. So doing the best I could there. I immediately, before we went back on, I was like, you guys got the nitro ready to roll again? They're like, yes. Okay, good. So nitro didn't cut it. we had to incorporate Clevoprex. We had to give fentanyl just to keep the pressure below 80. After HCA, surgeon instructed to give sodium bicarb upon rewarm. Waited 5 minutes because that's just a practice that empirically I've used to reestablish flow and oxygenation systemically. And these were the first gases, right about 8 minutes post. So gases don't look terrible there. So I was thinking maybe I dodged a bullet and did all that extra work for nothing. But ACT stopped at 500, gave an additional 5,000 units. Slowly started working my volume back into the bag that I sequestered off my recirc line. But the gases were routinely acidotic, as you can imagine, 28 degrees, 41 minutes circ arrested with only selective ACP. But when the pressure was under the control, I was like, okay, I got to get this flow off to help kind of blow off this acidosis. He was still a little hypercarbic. We were giving bicarb routinely. And I was able to get up to 7.5. But as you remember, with those flow characteristics on a Terumo, 7 liters per minute is your max flow. So we got up to 7.5. Was adjusting my gases accordingly, and I started noticing the condensation just dripping rapidly. And I was like, I think it's time to pop the second oxygenator. So I told the docs, I'm like, not really concerned about an oxygenation status, but it was more of a flow characteristic. So came down on my flow real quick, slowly opened up the second oxygenator, let it flow through the recirc for about 5 seconds, popped the outlet, and went back on flow. So, and these were the gases you see here were what they were set for both. So, we were clamped for 173 minutes. By the time we replaced the root, we did it with a 29 millimeter St. Jude's Master Series valve conduit and reattached the buttons. Interesting point, if you guys have EAOI chart sizers, doesn't work for that weight. So warmed for 122 minutes to get from 28 to 36. And every half an hour, we had to give an amp of bicarb, not surprisingly. There's just one of the pictures of the flow that I took. So that roller head was screaming. So case wrap up prior to clamp, I did give a hot shot, 400 cc's empirically. Wasn't mad because I had to give some amiodarone, and we do that on every patient. That helped my hypertension, and also gave 2 grams of mag. Reperfused 4 minutes post-clamp, resumed ventilation, and when we did that, I clamped out the second oxygenator and came down on flow and started to fill the heart. Gave a gram of calcium chloride, and 221 minutes later, I was never so happy to start protamine. 500 milligrams of protamine. So I've set numerous records on that day, none that I'm proud of, but I'm glad that this gentleman came off, and he came off once and he stayed off. So able to hemoconcentrate 600 mLs. He peed about 600 during the case, and total del nido volume for the case was about 2230. Post-protamine gas, ACT came back to normal, 0 hepcon. Gas looks pretty good, right? Minus the base def. But that's what I was dealing with the whole time. PTINR was definitely going to be skewed. We knew that. So they started the gamut. You can read the blood products, the platelets, FFP, 10 units of cryo, and all the cell saver volume. That was my real hemoconcentrator while we were on bypass anyways. So gave a total of 1805 for the case. So how's he doing post-op? On transporting, we had to put him on pretty good hit of peak for 10 and 15 liters of O2 just to keep his O2 sat above like 86 after we come off. So post-op day 1, he was awake and alert, very irritated, but still followed commands. The problem was always going to be, is he going to be able to ambulate? They did have to increase his peak to 12. Post-op 2 to 6. This is where it kind of got scary. He got encephalopathic and very lethargic. He was bedridden. So they put him on another low-dose heparin dip to prevent potential PE and mechanical vac, the anticoag maintenance. And surgeons believed that the encephalopathy was due to his ARF post-op. Post-op day 7, started PT, not able to annulate. They started doing the limb movement in the bed, but they were able to extubate, so that was good. Post-op day 10. Precipitous drop in platelet count, run a HIT test panel to find a positive ELISA. So again, we did not know this preoperatively, but that was just the joy that just kept on with this good gentleman. And I'm glad we found it. So we immediately switched him to argatroban, and I had to unfortunately re-intubate a day later. PT rounded again with the limb movement exercise, and they did range of motion exercises in the bed. Good news was, post-op day 20, they decided to trach him to get that tube out. And day 21, he showed drastic signs of improvement after the trach. Was able to sit in the chair. And post-op 24, 26, they started doing PT twice a day and had the ability to walk. Bed weight showed that he was 220 kilograms, so he had lost a little bit, and he was able to walk on 26 and 27. So lost 20 kilos during the stay. He had speech dysphagia due to intubation and his size, and was on a slow pace of full liquids and primary source of tooth feeding his nutrition. Psychologically, the nurses labeled him as flat effect with poor coping mechanisms. Not a surprise. Hospital stay was 28 days, and he was discharged to a local rehab facility. Today, he's home, he's walking, and he's down 60 kilos. So this is what my discussion is and what I want a lot of questions on from you all right before lunch. So considered flow and corrected BMI, like I said before. I believe it would have hurt him post-HCA with his ketoacidosis and his length of circ arrest time. So it was one of those things that I did consider. I wish I had a centrifugal pump, but as I'm talking to my colleagues out here, they're kind of like, maybe you don't wish you had a centrifugal pump, but his chronic hypertension, and I would have only been able to limit so much on a centrifugal head. So I was kind of you guys made me feel a little bit better about myself after that. So I thank you. Definitely should have cooled more. But how much of his ketoacidosis was a factor in rewarming? Got me to thinking, especially with Paige and with perfusion students. How many times do we prepare for this? I mean, I actually had done one other case prior on a 360-pound man that I did not cut a tandem in, but ever since that day, I think that was my 4th ever case as a perfusionist. I said I would always be ready for that. So, and then it got me back to thinking, 20 years ago, we used to put bypass lines on our oxygenators. How many centers still do that here? Not very many. I mean, that may be a good practice to consider, to think about. That would have been very easy to go on normally and then just cut an oxy in tandem, or if you have to replace. So not a lot of recent studies on tandem. I took a look, and the last one was 2013 for a bypass case, and the most recent one was 2020 on an ECMO patient for pigs. So I'd be interested to see more stuff that comes out of that. This was an emergent case. Didn't have time to get a heater cooler to wheel it in. The room didn't even have electrical capability to add a second heater cooler on my wall. I had additional O2 time. Wish I would have run a tag, and should we have flown corrected mass for ACP. So that was my wonderful Saturday in October. And this is a picture of that patient with our surgeon that kind of looks like a little kid standing behind him. It always cracks me up when I look at it. But that was the mammoth man that we got to do it. So I'm open for questions. And there's my team. So.
Great job, Keith. We've got time for a few questions. You kind of answered the question that I had about the consideration for BMI and correcting for that. Do you feel like that you didn't seem to have issues supporting him prior to cooling at normothermia, that sort of thing? And then, of course, you mentioned it may have hurt you if you'd reduced your flow targets at the end because of due to clearing the acidosis. Do you, Mike, did you think through about would it have necessarily been the flow that was the problem though, rather than just the circ arrest and a buildup and just you wouldn't have cleared it anyway? Or what do you think about that?
I wasn't really sure because he was on a good whiff of insulin too, and his sugars were still routinely high. I just, with that chronic umbilical hernia and just doing the best I could without overflowing or breaking a fiber, which is my biggest worry. And the new oxys with the inline filters, it's not really the oxygenator, it's more the filter that you're worried about. So it's a great question, but I don't know if it would have made a difference as far as flowing lower. But when he came off, he kind of stayed the same. Like there wasn't a difference of me flowing versus him being non-supported by bypass.
We have you asked about, I think, a bypass line or a pronto line, as Bob Groom described a while back. We didn't used to do those either. Kind of don't know that it's necessary all the time, but you don't need it until you need it. So we did set up a kind of a protocol for our institution that if you're going to run over 6, if your cardiac index target, which we run a 3.0 on most folks and a 2.6 on adults, if your 3.0 target's over 6 liters, or you expect to be on bypass longer than 6 hours, then we put one in.
Yeah. That's
again, that's an arbitrary,
yeah,
established time, but
yeah, that's great practice. I mean, from a safety aspect standard, we're highly considering that as well. Go ahead.
We got a couple online questions. The first one is from Hunter Bergamasco, saying, when doing selective antegrade cerebral perfusion on the patient with abnormal body size, would you recommend targeting your flow based off actual body size or ideal body weight?
Oh, that was the question that I had as well. I knew what his actual weight and what his flow was, but when I had initially flowed lower, if you would have calculated his normal flow, I didn't have it in the presentation, it was like half. So I started at half, my pressure was only 30 on the right radial A line. So I'm like, oh, I gotta jack it up a little bit. So I went to the calculated, and when I went and calculated, that's when the surgeon was able to start to see the volume come back via the circle. So we just stayed there, and he was okay with that. And that's why they did that post-op C2 when he had his, when he got encephalopathic. They wanted to make sure it wasn't fluid shedding from flowing that high in the brain.
The next question we have is from Mara Roman asking, did you measure lactates throughout this case?
We don't, and I wish we did. I think that would have been highly beneficial in this case, but again, I don't know what we would have did a little different because we were routinely given bicarb anyways. So, and it would have helped us maybe with my flow, but I can imagine that his lactate was probably still higher than normal anyways.
The last online question we have is from Amber Balak, who says, if you were ever presented with this exact situation again, would you use 2 oxygenators?
I think I would. This gentleman was I did hear that this gentleman was a college football player in his earlier life, and he was only 46. So I was thinking the best I can from a strategic situation for oxygen demand. So yes, I would. If I had to do it all over again, it's better to have it and not need it than need it and not have it, in my opinion.
All right, thank you so much.
Yeah.
I just have a comment about bypass lines. I think maybe we should rethink that because you obviously needed it. The other thing that we do at our institution is we transduce that line, and we've been able to diagnose high pressure excursions and mitigate it. You never know when those are going to come up. And especially with the size of your patient, you could have had a high pressure excursion. So that's another reason why it was good to have a roller pump. Because if
Absolutely.
you would have had a centrifugal head, you couldn't have done anything for him.
Yeah, you would, yeah, that's absolutely, firmly agree.
Keith, great talk. We had a chance to talk last night, at dinner, and we talked about some details in this case. But one question I have for you: your discussion with anesthesia and dosing weight versus actual body weight, and how that BMI comes into play.
Mhm.
How was that discussion had with this size patient? Did they treat this patient for a dosing weight of over 500 pounds, or did they go a little bit lower due to adipose tissue?
They took the same approach that I took with
Okay.
ACP.
Yeah.
They started at corrected BMI, or
Okay.
like actually ideal body weight,
Uh-huh.
and then they adjusted from there.
Okay.
So, but we already knew that he was going to be chronically hypertensive.
Sure.
So that was just something that we adjusted as we went.
Excellent. Yeah, I just want to make sure to see how anesthesia was in play with that.
Yeah.
Yeah, thanks, Keith.
So
Just a quick question. Were you using vacuum assisted venous draining or just gravity fed?
well, when I first went on, since I went to the half inch, I didn't originally use it because I was afraid it was going to come back so fast that I wouldn't have a lot of time to deal with it anyways. But when we came later in the case, after we went back on and I started working things in and we started losing a lot of volume for the cell saver and stuff, I did initially just crank it on just a little bit, like -10. So yeah, didn't use a lot of vacuum. Didn't need to. So thank you all.